let's start by looking at the question, is the low back always the problem in low back pain? What is the evidence we have around this piece? So we have actually had about a decade and a half of evidence to suggest that low back pain and pelvic health concerns are highly comorbid. Right? Again, comorbidity, they occur in tandem. We're not talking causation, right? Correlation. So Paul Hodges and Michelle Smith back in 2006 looked at 38,050 women in a prospective 5-year study, looking at trying to predict what were the strongest predictors of who would have low back pain in that 5-year period. And what they found was the strongest comorbid factors were pelvic floor health issues and respiratory issues, breathing difficulty. So the top and bottom of the canister. Now that's an interesting construct, and we're going to think about that a little bit more. And I wonder if where some of that went was to say, well, if the pelvic floor is involved and the diaphragm is involved, maybe the whole core is weak, right? And that kind of led into sort of our fascination with core strengthening over the last couple of decades. But in fact, the research hasn't really bore that out. And we're going to talk about some more research that connects pelvic floor health, low back pain, and the diaphragm to too much tension in the system. Eliason then did a study in 2008 where she looked at 200 women with low back pain. And what she found was women with low back pain, 78% of them in her study also had comorbid pelvic floor health concerns. Then Wingerden did a study on both men and women, so that was kind of cool. It was never published. When I talked to JP about the study at the First World Congress of Abdominal Pelvic Pain in Amsterdam in 2013, it was a poster presentation at that point. They looked at 1,636 patients. And for women, 63, or about 2/3 of the women with pelvic girdle pain had pelvic floor health issues. 57% of the women with low back pain and pelvic girdle pain had pelvic health issues, and 1/3 of men. So again, we're going to talk about Candace as a female patient. We're going to look at the research around connecting low back pain in women with pelvic health concerns. But let's not forget our male patients as well in this scenario. This series of studies connecting and correlating pelvic health and low back pain has actually crossed the last maybe 15, 20 years of clinical practice. And despite that, when we look at clinical practice guidelines for low back pain, we've got some in 2007 by Chu, in 2012 by Delito and al., and by Coos and Luciana Macedo and others in 2010. All these clinical practice guidelines do not mention the pelvic floor, do not consider the role of the pelvic floor in low back pain. So I think we have been missing this opportunity for a long time. When I talk about pelvic health and low back pain being siblings, we need to really understand that they come from the same family. And the problem is there's a lot of kind of sibling rivalry going on. There's not a lot of strong connections and strong familial bonds. We're going to take a look at that sort of concept a little bit more deeply as well. So in fact, do we have research and evidence to support that low back pain and pelvic floor health issues are indeed connected, or siblings? They come from the same family. And so Dr. Sinead Dufour and myself and Brittany and Marie-José actually did a study. We started in 2015, and we were interested at that point. We published this in 2017, I believe. We were interested in the question, specifically, what is the prevalence and type of pelvic floor dysfunction among women with lumbopelvic pain? So we see these studies that have been done prior to the study where we've identified a connection or a correlation, but then no one actually looked at the pelvic floor to say, so is the pelvic floor weak? Is the pelvic floor overactive and tight? Is it discoordinated? What is it about the pelvic floor in these women with low back pain that is of interest? And the assumption has always been that the pelvic floor is weak, and that also has led to excessive core training and core strengthening in our low back pain patients who have comorbid pelvic health concerns. So we recruited 182 women who presented to an orthopedic practice with low back pain. So these women did not come for a pelvic health concern. They came because their back was sore. 97 were excluded. Now, I think we need to look at that large exclusion rate for a moment. And we had 4 criteria for exclusion. The first was having a pain catastrophizing score of greater than 30. And we're going to talk about the pain catastrophizing questionnaire a little bit later on. But essentially, what that means, greater than 30 is severe catastrophization. And catastrophization just really means this is the worst thing that could happen. I'm not sure I can cope with it. So folks who are catastrophizing tend to have a bit of a worst case scenario sort of mindset. And that was our biggest reason for exclusion in the study. And so that's interesting because most orthopedic clinicians don't even consider catastrophization in their low back pain patients, and yet it's highly prevalent. Okay, we wanted to exclude these women because these are a little bit more complex patients. These are patients who we really know from the get-go we need to take a broader biopsychosocial approach with. So we were trying to really get at the mechanics of this problem a little bit more. So we excluded those. We also excluded anyone who refused to have an internal exam, anybody who was on narcotics, and anyone who really had English as a second language and was not able to read and communicate in English well. That left us with 85 participants with a mean age of 41.6 years old. And this was a double-blind study. That just means that the patient was blinded. The orthopedic therapist was blinded to the patient's screening questionnaires. The orthopedic therapist was blinded to the pelvic floor therapist's results of the study. The pelvic floor therapist was blinded as well, both to the patient's filling out of questionnaires and their distress questionnaires, as well as the orthopedic assessment. All right. 95% of the women in our study who presented to an orthopedic practice with low back pain actually self-reported at least one pelvic health complaint. That was 100% correlated in this blinded study with identifying in those women at least one objective finding of pelvic health issues on examination with the pelvic floor physiotherapist. So there's 100% correlation with that. Now, what we have seen in clinical practice as pelvic floor physiotherapists for a long time is that we actually see more overactivity, more tenderness on palpation than we actually see true weakness in the pelvic floor. And so this actually came out in the study. What we found was that of the 95% of women who had back pain, who had a pelvic health complaint, 71% actually had tenderness on palpation. 66% were found to have a weak pelvic floor. But what we also have to remember here that this was a one point in time study. We didn't do any follow-up with these women for the purpose of the study. And so what we find is that if there is tenderness on palpation, which represents overactivity in the pelvic floor, so if the pelvic floor muscles are being held in inner range, it stands to reason that women will be weak when you ask them to do a maximal voluntary contraction. And that's actually what we found was 2/3 of them were weak. What we find in clinical practice is we actually don't really assess their strength until that tension or tenderness is gone. And then about a half of the women who appear to be weak because they're being tested in inner range on that initial assessment are actually truly weak. So if we think about that, and again, that's an estimation at this point, but many fewer women were actually weak than were tender or overactive on palpation of their pelvic floor. And 41% of women actually demonstrated a pelvic organ prolapse. So that is a weakness, potentially coordination, potentially tension problem. Prolapse can be linked to any of those identifiable problems in the pelvic floor. So when we look at that study, the first question we really have to ask ourselves is if women who come to an orthopedic practice, even if we go with some of the early statistics from Eliason and al., for example, which showed 78%. I know our study showed 95%. But even if we say 3/4 of the women who come to an orthopedic practice with low back pain actually self-report and objectively have at least one pelvic health complaint, and if the majority of those women are overactive, what is the role of core strengthening for these women? If there's already too much tension in that inner unit, in that inner system, strengthening these women further potentially can only increase that tension, increase that overactivity. We also saw in the study that when they had an overactive pelvic floor, it was much more strongly associated with disability than when they had a weak pelvic floor. So again, we often say, we strengthen these women to help increase function, but that actually isn't, sort of bore out in the research at this point. So do we actually have other research to support the fact that, in fact, a lot of people with back pain have an overactive set of core muscles, pelvic floor, transverse abdominis, perhaps even multifidus? And what we know is that in neutral, pelvic floor, transverse abdominis, and multifidus are synergists. So if one is overactive, the likelihood of the other ones being overactive is higher as well. So we have actually two systematic reviews that have shown that actually people with low back pain are much more stiff, are much more guarded than people without low back pain. So again, that correlates with that increased tension that we saw in the pelvic floor. And one of the ways I might get a patient to understand this is I'll get them to make a fist. And so do this with me for a moment. Make a fist, and I want you to make a really tight fist and then move your wrist around and just see how that feels. Does that feel fluid and relaxed and easy? Or does that feel a bit tense and guarded and maybe a bit grindy? Okay, relax your wrist, relax your hand for a moment. And now just keep your hand relaxed and now move your wrist around, right? What's the difference? What do you notice? Does it move with more ease? Is there less tension, less stiffness, less guarding in the wrist and wrist joints as we do that, right? So again, if we apply that concept to low back pain, when we've been strengthening cores and telling people to keep their core stiff and tight when they lift, does that actually unload the joint, unload the structures, or cause more tension, more load, right? Some food for thought. So when we look at the question, are low back pain and pelvic floor health issues actually siblings? What we know is that, throughout the world, siblings grow up together and thereby facilitate the development of strong emotional bonds. But here's the problem with low back pain and pelvic health concerns, is there are very few clinicians who actually are well trained in both areas, right? Most musculoskeletal clinicians who treat low back pain don't understand pelvic health concerns, have not done internal training for the pelvic floor. And many pelvic health clinicians become very focused and specialized in pelvic health and have not necessarily created a lot of competency around a sort of orthopedic practice in regards to low back pain. So in fact, they're related, they're siblings, but these are not siblings that have actually grown together and have become close, and we understand kind of both sides of a coin.